Welcome. Good afternoon or morning to afternoon, depending on where we are catching you in the nation. Welcome to our webinar, Loneliness, the Untapped Opportunity for Managed Care. My name is Rachel Jacobson, and I am an Executive Vice President at Pix Health. At Pix Health, we create meaningful personal connections that are proven to reduce loneliness and social isolation and improve overall health and well-being. Our non-clinical holistic care solution identifies vulnerable members and offers them 24/7 companionship and support by combining an engaging app experience with our compassionate support center. We are so glad you've joined us today. We are going to begin with a panel discussion with our speakers and conclude with a question and answer segment. Audience members, please submit questions at any time during the webcast, and you can do that using the question tool, which is to the left of your screen. If you have any technical matters or difficulties at all, there is a help icon at the bottom of the screen. Click that and someone can assist you. And for those of you who might have to jump early or have colleagues that weren't able to make this presentation, a recording of this webcast will be available following the presentation. So as I mentioned, we're going to start with a panel and then a question and answer. Let me introduce you. It's my great pleasure to introduce you to a dear friend, colleague, and supporter of PICS, Gary Jesse, who's a managing director of Sellers Dorsey, which is a national healthcare consulting firm providing advisory services for Medicaid and public healthcare funding, policy, and program innovation. Gary is also the Deputy Executive Commissioner for Medical and Social Services in Texas, the largest division in the Health and Human Services system. Prior to this role, Gary served as the State Medicaid Director, where he was responsible for overseeing services and support for more than 4 million Texans, and as the Chief Deputy Director for Program Operations in the Medicaid CHIP Division. We are so thrilled to have you, Gary, moderating this webinar. It is my sincere pleasure to pass this over. Take it away.
Thank you so much. And I hope everybody is having a good day wherever you are. And we're going to be talking about loneliness. And so I'm pleased to get to moderate the panel today. Certainly, I'm learning as much as you are from our panelists, but want to set the stage for really our conversation. And so we can go to the next slide. So behavioral health, is more important than ever. And when we think about behavioral health, I can't help but when we say behavioral health is more important than ever, social determinants are more important than ever, all of these things that we have been working towards and supporting for the beginning of time in Medicaid and the many other social supports that we operate. But, I think what we're really seeing around behavioral health is more of unique strategies to try to address it. And so I want to just highlight a few of those. There's certainly been an integration of physical and behavioral health, and we've seen it every way. Some states have said we've integrated it, but it still looks pretty bifurcated within the system. We've seen MCOs integrate physical and behavioral health where they may use subsidiaries and it's still somewhat bifurcated. But really our goal around integration of physical and behavioral health is that we can focus on whole person care. And so many people that are suffering from behavioral health issues often spend more time with specialists that are treating behavioral health needs and less with physical health. And so there really is a goal around trying to integrate both of these in a model of care where we can focus on a whole person and certainly focus on overall health outcomes. I think the pathway for many states around effective integration and certainly addressing these types of issues is just with a managed care service delivery model. Many states still, let's say fewer and fewer, but some states still operate fee-for-service systems. And we know within those systems that people who depend on Medicaid are often just hunting and looking. We often refer to it as hunting and gathering systems where they're trying to access health supports. And we know within a managed care strategy that we can incent, we can have an MCO responsible for coordinating care, and we can use the right levers to make sure that they're focusing on what's appropriate for members. I think one thing that we see as resulting in this type of managed care implementation is that we've seen tons of innovation. Many of our managed care systems look just like fee-for-service in a managed care environment, paying a capitation, but really looking much like fee-for-service. But now we're seeing a lot of uniqueness, and MCOs really bringing innovations to their systems that really are intended to ensure that they're meeting the needs of their members. And so to that point, I often say that managed care should not be a one-size-fits-all model. Members' needs are different, and the types of solutions that we use to address those needs should be different. One thing for sure, what we're seeing across the country is that MCO innovations are indeed improving health outcomes for our members and certainly containing costs. And so next slide, we're going to be talking about loneliness. And I'm not going to read this excerpt for you, but I am going to tell you that loneliness is a condition that affects 1/3 of Americans. Loneliness is an overlying factor that likely is affecting members' mental and physical health. Lately, we have seen an outpouring of articles that are addressing social isolation and loneliness. Much of this has been attributed to the pandemic. And certainly, it's raised awareness of an issue that has been with us forever. Loneliness was an issue before the pandemic. We know that it'll be an issue post-pandemic. But I think more than ever, managed care companies, states, stakeholders, providers are recognizing the impact and the implication that loneliness has on both physical health and well-being. So we'll go to the next slide. Here's a few bullets for you. Over 1/3 of adults in the U.S. are chronically lonely, and this means more than 42.6 million of them may suffer from some ongoing loneliness. Loneliness increases a person's risk of mortality by 45%, and that statistic makes loneliness more dangerous than air pollution, obesity, and even excessive alcohol use. And I say that as I'm reminded that I have a wine refrigerator behind me in my office that I assure you that I'm not drinking during the day while I'm working. And then the last point here, as we move into some statistics for you, social isolation is associated with a 50% increased risk of dementia. And chronically lonely develop a distorted reality about the social world, and they have trouble breaking out of cycles of reclusion. So I think most of us have encountered, know somebody, and perhaps even suffer from loneliness. But why is this important, and why are we talking about this today? So we know that addressing loneliness within our Medicaid managed care population, and some of you are representing MCOs, some of you represent providers, some of you might even represent states. So whatever the healthcare system, delivery system that you are part of, we know that people are taking steps to improving their membership, their population, and by taking some steps to address this, you certainly can improve health outcomes. You can increase member engagement, and you can also reduce costs. And I'm always leery to start when we talk about managed care. I'm one of those that always hates talking about cost savings first, because we know the goal of managed care is ensuring people get the right care at the right time. And we know that a benefit of managed care and outcome has been cost containment. But certainly our goal is not just focused on cost containment. Addressing loneliness is especially important in Medicare and Medicaid populations. We estimate that $6.7 billion is a cost that's impacted to Medicare. We also see, as we mentioned in the slides above, that there's more focus on smoking cessation or anxiety, even about diabetes prevention. Loneliness has not often been a priority, even though we know it has an impact on health in general. So we've talked a little bit about MCOs are stepping up, they're implementing innovations, and we're going to hear about some of those innovations. I've had the pleasure of working with Rachel and the PICS team. I have been very impressed with the solutions that they're bringing to the market and the impact it's made on the lives of so many individuals who depend on the system of care that we all have the privilege to work within. During our panel today, we're going to explore how Medicaid plans have addressed loneliness, how they're tackling this epidemic, what the approaches have been, and what are the initiatives they're taking. We know that they're improving health outcomes, and we know that they're preventing unnecessary care utilization on the acute care side, and in the long-term services and supports continuum. And we also know they're cutting healthcare spending. So to get us started today, so we're not just all going to be talking to you. You're going to hear from some other people. We're going to also have some interaction from all of you, from wherever you are. So I want to introduce the panel, and I'll start with Dr. Ball. Dr. Ball served as the Chief Medical Officer of Banner University Health Plans, including their dual eligible special needs and long-term care plans. Within the Banner University Health Plan, they cover 200,000 Medicaid, dual eligible Medicare, and long-term care members in Arizona. He was responsible for leading initiatives around building collaborative value-based networks of patient-centered medical homes and created an interprofessional home care team for high-risk patients. Also joining me is Joel Conger, and Joel Conger is the Director of System Transformation at Molina Complete Care of Arizona. Some of you might have remembered them originally as Magellan Complete Care. Responsibilities of Joel's include community outreach, identifying social determinant trends within Molina's enrolled membership, and working to address gaps in care. Prior to working for Molina, he was Vice President of Healthcare Strategy at Crisis Response Network. And so I want to kick off a question, and we're going to poll our member, all the participants here. So grab your mouse, and if you could answer this question. Do you have a solution in place that directly and specifically addresses loneliness? Click that mouse. And Renu, I'll yield to you. I'll know how long we wait to give participants a chance to respond.
Gary, we have about 54%, so let's see what at least a little more than half of the audience said.
Okay. Well, you're in the right place today. Looking at these results, some of you didn't even respond. We're not going to shame you. We're not going to share your responses. But overwhelmingly, when we think about solutions to address loneliness, 23.1% of you that responded indicated that you did, and 76.9% of you indicated that you don't. And so I want to ask our panelists, what do you think about these results? And maybe I should say, Joel, what do you think of these results?
Yeah, I want to be surprised, but you know, we as a young MCO that just launched in October of 2018, I can tell you that loneliness and social isolation were not on our radar either. But once we began to explore and learn more about the impact that these basic social determinants can have on folks' overall well-being, it became crystal clear that we needed to find a solution that was going to allow us to better identify these folks and engage them and hopefully be able to address whatever might be driving that sense of loneliness, which, as you said, Gary, it's tied to so many other things. Just looking at most recent survey of that PICS has completed on behalf of our membership, of the folks who scored as lonely, 84% also scored positive for depression. So it's clearly something that needs to be addressed and needs to be identified. And with the right tools, you can really make a difference for folks.
Thank you. Dr. Ball, do you want to react to these results?
Yes. Can you hear me? Just do a quick sound check.
We can.
Okay. So one, in regards to this, I think it's pretty consistent with what I had thought, that the awareness through MCOs and healthcare providers is sort of low to maybe medium. I will give some national players credit because it certainly hit their radar screen. For example, Cigna put out a white paper and an initiative regarding appropriately termed chronic loneliness, differentiating just the loneliness any one of us might feel from an entity called chronic loneliness that you referred to in your introduction, Gary. And also, I'd like to add a couple comments to how you introduced this, Gary. One, you had mentioned that about a third of people experience chronic loneliness, but I would say our experience at Banner University Health Plans has been certain segments of your population experience very different prevalences of chronic loneliness. For example, our members with serious mental illness, consistent with the literature, are experiencing 75+% prevalence of chronic loneliness. And that's important because obviously members with serious mental illness are also a very high utilizing, high spend population with a disproportionate share of healthcare spending. The other point you brought up, you mentioned loneliness and social isolation. And while they overlap, I really think it's important to differentiate those two. And if I could just give a quick summary of sort of my journey. One, doing utilization management rounds decades ago, we certainly recognized people that were socially isolated were more challenging to put care interventions for, right? But we sort of stopped at social isolation. Do they have a support? Do they have someone living with them? Then I started reading, that interested me, and I started reading the literature, learn more about social isolation versus loneliness. That led me to do an analysis of our health risk assessments within our dual eligible special needs plan. And if you can think of 4 groups defined by whether they say they have a support person that they can call in case of emergency versus if they feel lonely. The population that was the highest spend were people that said they did have someone available, but they felt lonely. And that's been recognized. And you could imagine, just sort of imagine that for a minute, having people around you, but you feel lonely. They're not responding really to your needs. You're not connecting. And that population is very vulnerable. And obviously COVID has sort of laid this all bare. And I know Joel made some prior comments. Thank you.
Thank you. Well, those of you that have tuned in, that make up the 76.9%, you're in the right place. And it's never too late to start and how we implement systems of support to address loneliness. The next slide, and we'll get into our questions. It's really around, clearly, some of the individuals tuned in today do not have awareness of the impact of loneliness, or perhaps they do and they've not yet implemented a solution. But I'd like to ask, and Dr. Ball, I'll ask you first, in general, how would you characterize the industry's overall level of awareness of the impact of loneliness on patient health and cost of care? And just to add one more question to that, do you think most plans or executives within plans are prioritizing loneliness in terms of addressing it? And why or why not?
Well, I addressed a little bit of that in my prior comment,
Yes,
but I
you
would
did.
say I think there's growing awareness. The reality is, and I'm speaking as a healthcare provider, we often jump to what are we going to do about it? And I think that's the biggest barrier that folks are arriving. So for me as a clinician, if there's a disease entity that I have nothing to offer for, in a way, you sort of deprioritize it, right? My role is more supporting a family through that event. So I think that's really the biggest barrier that executives are running into, which is somewhat interesting because, to be honest with you, that's exactly where I was. When I was going through my journey of learning more about it, I was intrigued by it, but I was sort of left with, well, what are we as a health plan going to do about it? And some of that was reading, actually, in the United Kingdom is quite a bit ahead of us on this because they, as the National Health Service, have really recognized and completed cost analyses of the impact of loneliness on their population. They've actually funded interventions to identify some evidence-based interventions that can be done. And I know PICS has integrated some of those interventions into their program. I will also, if I may add, Gary, just what really galvanized my belief that we as Banner University Health Plans should focus and target loneliness was really the awareness of this chronic loneliness, and that we say that as one word, but really it's a cluster of emotions that includes anxiety, depression, learned helplessness, pessimism, hostility. So you can imagine you do get into a little bit, some of these members really, and patients do get into a bit of a vicious cycle where they experience rejection, they feel lonely, they're more hostile. Obviously, people around them are less likely to hang out with them, and it just creates more loneliness for them. This is what we're talking about when we're talking about this chronic loneliness. And, I imagine, that when you look at the pandemic, people have talked about a lot of these behavioral issues, but I think it's pretty clear to all of us. This pandemic did not all of a sudden create genetically a lot of people who all of a sudden are susceptible to depression and anxiety. It's loneliness that really ignited the fire of all this other cluster of emotions that come with loneliness. And as an epidemiologist, also health plan CMO, I was always focused on what is the target, the underlying target, more the root cause that we could address. And that's through this journey that I went on, identified, I think it's loneliness. And then fortunately, as we'll talk about later, I did eventually meet PICS Health. And so finally, I had someone that would help us with what we could do about it.
Thank you. Joel, do you want to contribute? You want to add some to that question?
Just a little bit. I think if we're talking about, Arizona specifically, I can see that awareness now is way more ever present than it was 3 years ago. And I think we've got to attribute some kudos to the state Medicaid agency here for really challenging the Medicaid plans to figure out better ways to engage their members through, digital technology, through different means than just the kind of the old proven way of trying to engage members and get folks to connect better with their health care. So I believe awareness is rising. I'm watching it all around me, not only in our plan, but in our partner plans that are serving the state of Arizona, that awareness is definitely increasing by the day.
Yeah. Well, a shout out to Arizona's Medicaid director, Jamie Snyder, who's a friend of mine and one of the best in the business. I think your point around the state impact and what states pay attention to, I do think that your Medicaid program should be a partner in helping identify and prioritize. But we also know that that sometimes there are so many things that get prioritized that it becomes difficult to figure out where to focus, and you're constantly contract amendments and constant new focuses and changes and efforts, and there's a lot of start and stop that happens. But I think it's, conversations like this today that really help us center around what's important for the people that we serve. And I think around the points, Dr. Ball, that you made, I think it was exacerbated by the pandemic. We know that we saw impacts to our delivery systems we've never seen before. We saw changes even on long-term services and supports and the ability to have people going in and out of homes that provided interaction for people. Much of that ended out of fear. And we saw, really the focus on nursing home care, and then this focus on anything but nursing home care. We've seen so much, but I want to poll the audience, and maybe a few more of you will answer this time. And the question is, what area do you believe is most impacted by loneliness? And you can select all that apply. And we'd like you to go ahead and make a selection.
We have about 36%, 46. So maybe when it gets up and over 50, we'll share the results. There it is.
All right. Well, there's really no wrong answer here. We know that loneliness can impact all of these areas. And so I want to ask our panel, I want to ask you a question specifically. Based on your experience, and certainly the two of you are very well suited to address this question, why do you think loneliness is an important issue to solve for the members that you serve? And Joel, why don't we start with you?
Sure. And I'm going to kind of reverse engineer this answer, because again, before we implemented the solutions that we implemented, we weren't really clear, that loneliness was such a causal factor behind so many different things. But, and I'm going to obviously call out PICS, we launched that application in October of 2020, which was right smack dab in the middle of the pandemic. And again, we were the new plan on the block. When we went live on day one, we had 174 members. Now we're up to 46,000. So, we're kind of the little guys. So, our original reach when we started to onboard folks wasn't super significant, but slowly but steadily we've continued to partner with PICS and their onboarding and their engagement center. And slowly but surely we've built up a pretty solid user experience. And what we're seeing from those users who are engaged and who are, triggering as lonely, who, you've got the corresponding positive indicators for depression. We're seeing pretty significant impact on what their pre and I hate to do, Gary, just like you said, I hate to boil it down to dollars, but a lot of times that's where we can tell if we're making a difference. So looking at their pre onboarding cost experience versus 6 months post, we're seeing incredible results that loneliness was driving prior. We've realized, I think a total of a 57% cost reduction in service in service utilization pre and post. And what are we seeing from that? We're seeing significant reduction in ED utilization. We're seeing significant reduction in inpatient utilization. But on the flip side of that, we're seeing also, I was blown away, but 73% of the folks that we queried here in the last month or so who are onboarded, they actually are feeling more connected to their health plan and more connected to their health, care delivery. So we're, again, without really knowing what we were kind of going after at the offset, we've learned a lot of lessons, and it's very clear that loneliness and social isolation, although distinct, they do play significant roles in folks' path to wellness and feeling good. So
that's great. Dr. Ball, yes. I know you shared some experience already. I'd like to really ask you the same question.
Sure. Well, so Arizona integrated behavioral health into physical health traditional Medicaid program some years ago, and that's what spurred us to bring in vendors and look for behavioral health solutions to help us through the integrated whole person care initiative that the state was doing. I've already mentioned why, as we looked at those vendors, we connected behavioral health to loneliness. So the other part why we ended up choosing to partner with PICS was really their combination of technology and humans. And that's been shown time and time again that you need that combination in healthcare to really see the benefits of technology. Then what I can say now more confidently than I did when we started was our Banner Analytic team took a cohort of our members that experienced PICS Health, compared it to a cohort that did not, and they did propensity score matching to make sure these were sort of equivalent groups. It was a high cost spend, people experiencing transitions of care. And what we ultimately found was there was over the 6 months, of the initial 6 months we did the trial, there was over $5,000 of cost savings among those that worked with PICS and were supported by PICS. Of those dollars, about 51% of that med spend was saved on hospitalization, 41% on emergency department use. So I agree with what Joel experienced. And that was really impressive to me because over the years, we had done a lot of initiatives to try to decrease Medicaid spend in the emergency departments and clinical interventions that frankly weren't terribly successful. So we were really dazzled by this result. We did think, and we still do think, one of the reasons was because of the long engagement that these members had with PICS Health, which was over about, almost 2 to 3 months of engaging with the PICS Health tool and their compassionate care center. And we felt that was probably important in really changing people's overall healthcare utilization patterns. Thank you.
That's great. And I think the statistics are looking at the responses from the team. We often say some of these same categories. We say effective managed care can impact these areas, but effective managed care is really effectively addressing the conditions and issues that affect membership. And so it's great to see what the impact has been on your approach and what you've seen as a result. We can change
Gary?
To the next one. Yes?
Yeah, I might just quickly add for the audience, I have only done this health plan type work always within an integrated healthcare system that include hospitals, clinic, faculty, practice within our university system here in Arizona. So even though, sometimes there can be a little contentiousness between those different parts of the healthcare system, it's always been a collaborative effort. So frankly, a lot of the work I do on the health plan side has been appreciated by emergency room doctors and our hospitalists who are also looking to decrease unnecessary utilization. And that's only been exacerbated, obviously, during the pandemic. But it's always had that sort of global perspective on it. Thank you.
Yeah, I think that's a great point. So moving into the next question, and this is really targeted around implementing a loneliness solution. We know that it's created a lot of benefits for plans, and both of you have already highlighted some of the success that you've seen. And so, not asking you to try to restate what you've already said, but specifically, I would like you to add, and Joel, you've already added some statistics for us, but you want to add additional information. What are the benefits that you've seen since that you've actively been addressing loneliness? And is there anything that's been most surprising to you? And Joel, we'll start with you.
All right. Thanks, Gary. So one of the probably most impactful experiences that we have had since implementing our loneliness solution is that part of the PICS application, it's constructed of multiple different assessments, and depending on how a person who is using the application scores, it can potentially trigger an alert, and that alert will go to the Compassion and Contact Center, and depending on what's going on, that we've kind of developed, it's almost like a bat phone, for lack of a better way to describe it. But if one of our members triggers something that's considered an urgent referral, then that actually comes directly to me, and I'm able to do air traffic control. And if it's a we've had instances where someone's having a hard time getting durable medical equipment, which could have very easily turned into an ED visit, or we've had someone who was experiencing a lot of stress because they were losing housing. But because of this connection between the application and the plan and our ability to kind of respond in almost real time, we've been able to intervene, whether it's connecting someone to our housing specialist, or employ some of just the real basic social determinants that can drive folks to have not the best or optimal outcomes. We've been able to intervene and do meaningful interventions, and we've been able to realize that impact from our members' personal experience, and we get to hear about it, and we get to hear the stories of like, oh my gosh, I had no idea that just by using this application, I was going to be able to, if I'm going through a hard time, and be able to have this direct connection to my health plan. So above and beyond, the numbers and the dollars, I think what's most important to us, and what we kind of keep in mind is at the end of every single one of those outcomes, there's a human experience tied to it. And that's really been one of the most significant benefits that we as a plan have realized.
That's great. And Dr. Ball?
Yes, I scribbled a couple things down here in response to your question. So thinking two different categories, 2 points I wanted to make was, one, again, I want to emphasize the point of unnecessary or avoidable utilization. For instance, there's plenty of studies that say the more chronic conditions you have, the higher medical spend you're going to have. Yes, that's pretty obvious. But the question is, what are you going to do about it? And that is the ramification of having these disease states. So for us, it was really looking, what is the trigger? What's the underlying root cause for avoidable and unnecessary utilization? And that's where we have come upon, loneliness. And I would also point out that obviously, as everybody knows, people with multiple comorbid conditions cost more and have more challenges with some of these issues. And that's why I'm not really a fan, and in the past we have not found disease-specific interventions to be very helpful. Like a specific diabetes, our care managers would call our uncontrolled diabetics. Diabetes was the least of their issues. It was transportation, it was stress going on in the household, it was social isolation, et cetera, et cetera. I think that's really critical. I'm a strong believer now, over the last 10 years of sort of working through this in a slow and circuitous way, that loneliness is one of those root causes of this avoidable, unnecessary healthcare utilization. Now, you also mentioned surprises. So I had two big surprises when we initiated our partnership with PICS. And we did a short, before we actually dove in, we tipped our big toe in the water by doing a small pilot with them. And before I tell you about those two surprises, in full transparency, I do have to admit, I'm the grandson of a wonderful woman who Grammy used to tell me when she first saw her first motorized vehicle, she knew that was just going to be a fad, that horse and buggy was so much quieter, much more comfortable. So I have to admit, I'm not really a big tech kind of guy. So the two surprises came. One, PICS has this chatbot, Pixar. I simply did not believe human beings would be interacting with this Pixar on a regular basis. That was one. What I was really jazzed about was a function of the PICS program called care circles, where individuals would be connected through the technology to their natural supports to help them out. That's what I thought was going to be a success. I was wrong on both parts. So when we did our initial pilot, we had much higher engagement with this chatbot Pixar than we had ever had with any other intervention we had tried. We had members that were conversing, meaning they would put in a comment and get a comment back from Pixar over 60 times a day. I simply could not believe it. And the important part of this is, and I think this is really critical clinically for loneliness, is a lot of these interactions were occurring throughout the night, in the wee hours of the morning. So, and this is consistent with the medical literature, which I have subsequently learned about. Loneliness and sleep disorders have a clear relationship. So the most cost-effective way to help people in the middle of the night was clearly these interactions they were having with Pixar. So that was one. Then on the care circles, what we found out, in our initial pilot, we're on a group of super utilizers for our health plan. So they were sort of a distinct group. Pixar and us at the health plan really tried to get their care circle to attach to them through this technology. Unfortunately, these people had burned their bridges with their friends, family, and natural supports. And that's where the critical part of PICS having the compassionate care center that has human beings answering the phone and supporting people is critical for this group of high utilizing people with chronic loneliness, that they can get that support, because they've often burned a lot of these relationships they've had with other people, in their environment. Thank you.
Thank you. I think those are all great points. So we have one more poll for the group, and I want to make sure we don't run out of time, because we definitely want to make sure we have time for some questions too. But why don't y'all answer this question and really use your first instinct. What type of Medicaid or Medicare member is most likely to experience loneliness?
Okay, Gary, we are just about at 50%.
Okay, great. So looking at the impact, most of you indicated elderly or older individuals, followed by transition age youth, those with pre-existing comorbidities. I think what we've learned through our experience is that loneliness affects all members. And in fact, it's often young people that are impacted at the greatest level. And so I want to make sure we have time to get to the mechanics of how the solutions work. So Joel and Dr. Ball, I'm going to ask you to quickly answer this question so we can spend a little more time on a couple of others. But why did your plan ultimately decide to target loneliness?
Well, quickly, this goes back to the Arizona State Medicaid. What they held an event called the Medicaid Innovation Challenge, and this is where they were really encouraging all of the different MCOs to figure out new and better ways to engage their members through digital technology. And it was an all-day event, and there were multiple, I believe there were 8 vendors who presented that day. And we came away with, kind of to Dr. Ball's point, we were just very intrigued by PICS, by this little avatar. How can it possibly be that engaging? But then, they have the data to back it up. And, we were like, it's a thing. And, we haven't really looked back. It was the data that was presented. It was the platform. It was the non-clinical, just ever present kind of surveys that you see in a lot of apps. It was that presentation, and just the whole design and concept behind the design that it helped us, really pursue the path that we've gone down and haven't looked back.
Thank you. Dr. Ball, would you like to tell us what pushed your plan?
Well, quickly, I think I've already sort of mentioned really behavioral health and searching for more of a root cause got us to loneliness. I would add 2 other pragmatic pieces. At the time, I was a CMO of a clinical area that was totally stressed because we had fortunately won a couple bids and our Medicare plan was growing exponentially. And so our clinical staff was absolutely swamped. So what worked out well is, I remember I mentioned PICS has the Compassionate Care Center. We partnered with them, and they really handled most of those referrals. Social determinants of health to community resources, and they helped that for us. Then what happened organically over time is that started to work its way into our care management rounds. But it did it in a way that was organic and matched the capacity of our clinical staff to handle some of these referrals themselves, and we got the handoffs going. So that worked very well for us. I think that was critical. The other piece that, again, I'm not really the techie, and you know how your IT teams really want just one Swiss Army knife, right? All these apps and things all connected. But how many of us have a Swiss Army knife in our kitchen? Because you need different tools. And so what worked out well is the app for PICS just complemented other tools we had in our kitchen for these services and integrated well with that. So that worked out very well for us.
That's great. I'll tell you that as a former Medicaid director, you get an opportunity to meet with lots of different companies, and you get to see lots of different solutions. And, and I will say, when I first met PICS and the solution, I was intrigued, as you all were, with the use of the avatar. But I will say that one of the things that was really most impressive to me, and one thing I feel very strongly about in really the care coordination space, is that MCOs, despite their best efforts, it's impossible to ensure that you have a service coordinator available to address a member's need whenever they need it. And so I really loved the idea of having a support like this that could address a need, which we know is there, but also connect people to social determinants of health and other sources, and really in a way supplementing, not supplanting, but supplementing the service coordination that your members needed. And, you know, we know members, they choose a health plan, most don't choose, they get defaulted, and then we know that most don't change. And so to me, it's imperative that we drive all plans to ensure that they're supporting members in the best way they can, because they often don't know what they could be getting from another plan, you know, because they never experience what other plans are doing. So, you know, it's like raising the ship all at the same time. But I was really impressed. The ROI, the return on investment, that's everything now. You know, anybody you talk to, it's like, what's the impact? You know, what's the data? And I've met some people that had very innovative solutions, and I thought they'd be great, you know, very successful, but they can't get the MCO's front door because they can't really relay what that means, you know, what the bottom line is. So anyway, I'm going to stop talking and move to the next question, so we have time to really hear about how your solution's working. But you can change the slide. So what do you see as some of the biggest challenges when you're targeting loneliness? And if you could share with us what you were looking for specifically when you made the decision you were going to focus on loneliness, what is it you were looking for in a solution? And Dr. Ball, why don't we start with you?
Okay. Gary, I'm a little concerned about time, and I see there was someone who put a lot of questions in the Q&A box.
Okay.
So
well,
go ahead.
Yeah, no, I mean, what if I ask you a different question? Maybe I could ask y'all to really highlight how the approach works. Because I think a lot of people are on here, we keep talking around picks, we keep talking about the avatar, we keep saying all these things, but I want to make sure people certainly can get more information after the session, but I think it would be helpful for people to understand how the solution, you know, how the approach you selected works. So could we maybe move, you know, this is real time. Could we go ahead and move to the next slide, and we'll just skip that piece for a bit. But I'd like to ask y'all if y'all could talk a little bit about your approach, and then also what your benefits have been. And so let's just kind of move this around in real time. And I'll ask either one of you who'd like to respond first. Whoever starts talking can be our first responder.
Sure, just a couple quick points I'd add. Obviously, I've already talked about utilization patterns, which was my responsibility at the health plan. But this tool actually engaged our members such that they really started using, you know, like our web page more and other pieces of technology. So I know that comes up, and that's one of the questions in the box here about overload of digital engagement tools. But the nice thing about this one is it's really based upon trust, right? This is not an alert to say, go get your mammogram and pushing you to do something. This builds first on just a trusting relationship, which then can grow into encouraging people to use preventive services, which has actually happened for our people that have used PICS and improved their utilization patterns for avoidable pieces. I'll leave it at that for Joel.
Yeah, I think just real quickly, you know, our approach was and is, how can we touch as many lives as quickly and as effectively as possible? And going through a huge transition like being acquired by Molina really kind of hamstrung us in terms of our marketing and how can we outreach our folks. So we had to lean in really hard and heavy on the compassionate call center to help us with that engagement. And knowing that support and that commitment to us, and then, you know, just getting those weekly updates on how many attempts were made and how many connections were made and how many, you know, users downloaded. That was probably the most significant piece for us. Was we had confidence in the application, but it was how are we going to get it out to folks, and how are we going to grow this, and how are we going to be able to, you know, impact as many lives as possible.
Great. Well, I'm going to ask. We'll go to the next question, and I might just I might ask Dr. Ball to just share a little bit of insight. what are some of the lessons that you've learned over time as you've been addressing loneliness with your plan? And what was most effective for treating it? And did you recognize anything over time? I know you both have shared a lot of insight, but tell us specifically from a member's perspective, what'd you learn?
Well, this segues well into one of the questions in the Q&A about tangible impacts on the member's life. Be honest with you, rather than hear it from me, I think hearing it from members is more important. So actually on the PICS website, there is a testimonial from 2 of our members that were part of that initial pilot I referred to, and talking about their experiences. So that was very helpful. Again, I've already mentioned some of my surprises and the efficacy. In retrospect, frankly, I would just have implemented this sooner and a little more robustly. Again, we were early on. We just started with a small group and then grew slowly. And I wish we had just sort of incorporated it to and contacted a larger group of our membership out of the gate.
I think that's great. I think the point you made earlier about when you found most the use of PICS, some being very early in the morning. You know, most plans don't have service coordinators and other supports available to address members' needs when they might need them. So I love the fact that you found as a part of this resource and the use of this tool that you were meeting your members where they needed to be met when they needed it. And I think that's great.
Gary, that's important because that's what the British have shown, that befriending services. And so we have, by regulation, we have a 24-hour nursing telephone, available. But people don't think about calling a nurse for loneliness, right?
Right.
And so this has been very advantageous and complementary to that mandated 24-hour nurse line we have. So great point. Thank you for bringing that up.
Of course. And so, Joe, I'm going to ask you this question, and then I want to make sure there's a question in particular that I'd like to address, one that comes up a lot, I think, when we talk about different innovative strategies. But let's go to the next slide. Joel, can you tell us what would be your perspective? Where should plans start when they want to address loneliness, when they decide it's time? And maybe they've been motivated by your comments today.
Well, I can tell you the time to start. It was yesterday, and it's just looking at your social determinants. Look at, and understanding that there is a significant causal relationship behind a lot of those that can be drawn and tied very neatly with a bow back to loneliness and social isolation. I think I could say that after talking about it for 2 years, but working on it. But it's really just looking at what's driving your utilization and start ticking and tying back. And the path gets really, really clear if you can see through the trees.
Yeah. Well, I think one thing you both have clarified for us today is helping us understand the impact of loneliness, that it has far-reaching impacts, but really tie to the question. So, how do you deal with the fact, and I'm going to add this question, so many plans are digitally engaging with members. And, and for some, there's always a concern that we're overloading our members' experience. What would you say about how did you handle concern about overloading digital engagement with your members?
I'll just say that that's incredibly real conversation that I'm a part of probably weekly now, is that, it's here's another solution. And the reality is that there is no wrong door. And as long as, there's a clear-cut path to, what it is that you're offering your members, and there's an explanation and understanding behind it. I think the more opportunities that folks can select what they want to do that's going to connect them better to their healthcare, the better.
I think that's great. Well, Rachel, I want to end with you because we're right at the hour. People want to reach out to you, want to learn more about PICS, specifically how y'all are addressing loneliness across the country. could you give our group some parting words?
Yeah, absolutely. First of all, I just want to thank Gary, Joel, and Dr. Ball. Thank you so much for your time to come on and talk about your experience. I feel overwhelmed and humbled to have been part of this journey of PICS from day one, and hearing the impact straight from you is a little bit overwhelming. So I'm so grateful to be here. But yeah, Gary, as you said, if anyone is interested in a conversation, has some questions, we'd love to have a conversation with you about how we're working with MCOs and managed care organizations across the country. You can see my email there. You can jump to our website. There's a fun form to fill out. Maybe you want to have a little 15-minute coffee chat. You know, all of that is available. We'd love to start that conversation and connection, which is really what the company is about. So thank you for the opportunity to facilitate this, to join, and thank you for everyone that joined on this incredibly important issue. We are dedicated at PICS. It is truly mission-driven from everyone at the company, and we hope to have the opportunity to connect with you.
Yeah, and you're now all ambassadors to address loneliness. So we hope you'll take what you've learned today and build on what you've already known, and really work to address the needs of loneliness across the members that you have the privilege to serve. Thank you for your time and attention. If you need to reach out to any of us, our contact information is there. I'd like to thank the panelists. I'd also like to thank Rachel and really the PICS team who really brought a solution, a really much needed solution to our system of care, and is really making a positive impact in people's lives. So thank you so much, and hope everyone participating has a great rest of the week.
Thank you.
Thanks, Gary.